The last class we went through the primary assessment and what are the components of the primary assessment. So we'll just have a quick recap of whatever we have discussed. So you have a sick child coming to you. So initially you have done an initial impression using your pediatric assessment triangle, and you have come to a quick judgment whether the child is sick looking or stable. And if the child is sick looking, what is the next thing that I asked you to do is to immediately connect to a monitors, and if needed put an IV access and start them on oxygen depending upon evidence of hypoxia is there or not. Next thing, you started your primary assessment with A, B, C, D, E. It is continuously here to identify, here to evaluate and treat. Identify, evaluate and treat. You have to identify the problem, you have to evaluate the problem, and you have to treat the problem. So that is the nutshell that you need to remember. So wherever there is a problem in the A, you need to identify what is the problem. Sometimes you need to evaluate it, and sometimes you need to straight away treat, because identifying itself, you know that this is the problem, because there is a secretion, you need to do the suctioning. So straight away you can start doing the suction. So A, B, C, D, E, what all things component that is needed, and some investigations that you need, you can ask in between the primary assessment. See, primary assessment or secondary assessment, wherever you want investigation you can do, but certain key investigations you wanted to know, like glucose random blood sugar, if the child is drowsy, you wanted to rule out a hypoglycemia, those things you can ask for. Maybe asking for a complete blood count is not needed during a primary assessment. Maybe a blood gas if it is warranted. If you feel that you need a blood gas because the child is going for probably a cardiac arrest, you want to know there is an acidosis or anything. So in that time, depending upon the criticality of the child, you can decide whether what all investigation you need at that point of time. So that is your nutshell regarding your primary assessment. Now coming to the secondary assessment. Secondary assessment, again, as I told, whenever you go from one step to other step, and not one step to other step, it is a continuous process. You have to have a continuous assessment of A, B, C, D, E. So wherever you do continuous assessment of your vitals, it is a continuous process. It's not a one-time process. So maybe after 2 to 3 minutes, you feel that there is a change in the vital signs. So you need to go back and do your airway breathing circulation again. So like that, when you go for the secondary assessment, make sure that your A, B, C, D is fine. And the most important thing that you need to remember is that you need to start with something called as sample history. So sample history. So that is the mnemonic that you can remember, sample history. So that is the secondary assessment. Start with, it has two components basically, your history taking and your full body examination, or you can call it as a focused examination. So here we have not done a focused evaluation. We have just auscultated, we have found out that there is some wheeze. We have not gone in depth in evaluating a respiratory system. So we need a focused evaluation you can do after your primary assessment in the secondary assessment. So the secondary assessment, as I told, it will start with the sample history, and most important thing in the sample history that you need to remember first is the signs and symptoms. So signs and symptoms is the first S that starts for signs and symptoms. So what are the signs and symptoms by which the child has come to you? So you need to make sure that what is the primary symptoms. So suppose the mother is complaining that the child had fever. So I am just giving you history, fever. And the next important complaint, the mother was giving fever, cough. So these are the two signs by which, symptoms by which the child had come to you. And now you have to elaborately ask what happened exactly, the type of fever. The fever started how many days back? So fever started 2 days back. So that is the next thing. Okay. So 2 days history of fever. Now you have to know what is the type of fever. Whether the type of fever is, whether it is intermittent, it is coming and going, it is coming and going, or it is a continuous fever. Fever is not coming to the touching the baseline. So when the temperature is coming back to the baseline, normothermia, and again shooting up, that is intermittent fever. So it is a continuous fever, the fever spike is always there. So that is a type of fever that you can understand. The next thing is that whether, what is the problem in children with fever, they can go have febrile seizures. So we need to have a quick control of temperature. So that is very important, because especially in children less than 6 years of age, they are prone to develop this febrile seizures. So you have to see the history, fever, in what type of fever, whether it is more towards the evening. So when the parent is complaining that fever for last maybe 1 month and more towards the evening, and there is associated cough, you need to suspect tuberculosis. So like that, all those things, depending upon the signs and symptoms, you can focus and come to a probable provisional diagnosis. So suppose the child is coming of fever and 2 days history of cough and expectoration, probably we are dealing with then lower respiratory tract infection. So we don't know, lower respiratory tract infection, that could be the reason. It can be a viral infection or a bacterial infection. After doing a blood evaluation only, we will be able to say whether it is a viral or a bacterial infection. So that is the signs and symptoms that you need to do. Now you have to have an elaborate. You just ask fever, that is not enough. You need to ask for other associated symptoms, whether the child had any associated symptoms. So what are the common associated symptoms that you can have with fever? So you need to have a focus where primarily is the problem is. So fever, just it can be a CNS infection, it can be a chest infection, it can be just a simple upper respiratory tract infection, it can be an infection to your abdomen, it can be urinary tract infection, it can be a small cellulitis. So you need to focus where exactly the problem is there for the child. So how will you focus? By the add-on associated symptoms. Suppose the child is telling I am having diarrhea and fever. So you are focusing that diarrhea and fever. So probably we are dealing with an GI infection. So probably the most common cause of a GI infection is what? A viral diarrhea. The child would have consumed something from outside, or the hygiene was not maintained, a viral diarrhea. So like that, you need to get a focus where exactly the problem is. That is the idea behind taking the signs and symptoms. Suppose the parent is coming in and the child is having fever and the child is drowsy since last two to 3 days, and also there is some abnormal behavior to the child. So what will you suspect? There is an infection to the brain. So that is the thing. So when we give fever alone, that is just a symptom. You need to have why the child is having a fever, and fever with lower abdominal pain, especially in a female girl, that is 15 or 16-year-old girl that is coming to you, 15-year-old girl coming with fever and lower abdominal pain. What is the most common differential diagnosis that you need to think is urinary tract infection. So like that, from your history, you need to have a focus where exactly the problem is. So that is the importance of just asking signs and symptoms. Just a fever, that is not enough. You have to ask for associated symptoms, and you need to get a link to that fever. Why this child is having fever? So fever, you should ask for what are the common associated symptoms that you can have is upper respiratory symptoms like sneezing, coughing, and all those things. Then the next important thing is that you can have expectoration. You can have thick purulent expectoration. Then CNS infection, what is the clue? You can have altered mental status, maybe sometimes seizures, decreased response. These are all signs and symptoms that is focusing towards the brain. And what are the abdominal pathology? It will be vomiting, multiple episode of vomiting, diarrhea. So this all will be focusing towards a GI infection. Then urinary tract, burning micturition. The child is having a burning micturition and lower abdominal pain. So this focus towards what? Urinary tract infection. Then child is having some joint pain. The child is having fever with associated joint pain. So the most important, you can have the child had a small trauma, maybe a septic arthritis, the infection to the joint space, or it can be non-infectious causes of fever is also there. There are some autoimmune pathologies like they can have non-infectious causes of fever. So the most common reason for fever is infection. So they can have non-infectious causes. Suppose a child is having an glomerular nephritis. So glomerular nephritis is again it can have a multiple reasons. It can be secondary to an other autoimmune pathology also. So they can have some autoimmune disorder. Suppose the child is just having fever and you are not getting a focus anywhere. So you have to rule out non-infectious cause of fever. So fever is just a sign and symptom by which you need to build up what exactly is happening. Similarly, whatever the complaint the child is coming, you have to build up what is the focus to that area. Suppose the child is coming with a joint pain. As I told, joint pain. Maybe it's a fracture which you have missed. So we need to ask that whether the child had any history of trauma. What is the reason behind that? That all those things will come under your signs and symptoms. So what made them come to the emergency with signs and symptoms? So these are the things that we need to elicit. So signs and symptoms, that is S for you. Next is the A, that is what? Allergies. Any allergies, not just medication allergies. You need to ask for what all type of allergies the child have. Maybe the child will have cow milk allergy, peanut allergy. We already discussed that in our anaphylaxis class. So allergies. So all these allergies history you need to elicit from A. So sample. Then P is for your past medical history. Past medical history. The child have any frequent hospital admissions, frequent hospital admission for pneumonia. The child had recurrent pneumonia, frequent admissions for pneumonia, any medication the child is already on. Suppose the child is already on some seizure medications. So all those past medical history you need to ask in here. What all medication, previous medical history, everything you ask in P, SAMP, M, again medications. L is last meal. So when the child had last feed, we have to know that how was the nutrition status, especially when we are planning for nutrition. The child has not been taking anything for last 24 hours. That means there is no nutrition supplied to the child. So we should know that. So when was the last meal? Then sample E is events. Events that brought them to the ED, because the fever would have been there since 3 days. But what made them come to the emergency room today, right now? Maybe they would have said, we are already giving paracetamol since last 2 days. Today, the fever increased and altered sensorium started developing. That's why we brought the child. Or suppose the fever was there since last 2 days and a seizure episode developed. So these all things, what brought them to the ED will come to the events. So basically, the secondary assessment starts with your detailed signs and symptoms. What made them? What are the basic signs and symptoms of the child? And ample, that is the next is A for allergies, M for medications, past history, L for last meal and events that got them to the emergency room. So that concludes our sample history. From sample history, what you have to do is that you need to have a focused examination. You need to have which all system that you need to evaluate. Usually every system we need to evaluate. Suppose a child is coming with fever and cough. Which system you wanted to examine first? Obviously a respiratory system. So focused examination means from your history and your clinical initial impression and your primary assessment, you have got an idea. Okay, I am going to deal with a patient who is having primarily a problem with the lungs. So your focus will be on respiratory system examination. Suppose a child is coming you with the abdominal pain, you will not do a respiratory system examination first. Focus examination means you will do an abdominal examination, which is the priority that we have to decide. So from that you can go other system, but ideally you need to evaluate every system. But focus should be on given to the system which you suspect from your primary assessment and from your history. Whatever history that you have got, suppose the child is coming you with a joint pain, you are going and examining the abdomen. That is no use. You have to examine the abdomen. I am not saying that, but primarily you have to examine that joint, and from that joint you need to come to the abdominal and other system examination. So focused examination means what is the focus that you are concerned about, that is the first system that you need to evaluate. And next important thing is that after focus evaluation you can go for diagnostics. So what all blood investigations that you need, all the diagnostics like CBC, you want a complete blood count, you wanted to know the CRP, you want to do an urine routine evaluation, you want to do a chest x-ray if you are not taken initially, you wanted to do all those evaluation. So those investigation that will guide you for a diagnosis, you can ask here. So don't ask for a routine evaluation, that is not needed. So if the child is coming with fever and lower abdominal pain, what is the point in asking a chest x-ray? So your investigation should be focused, and your investigation what you needed will be what you suspect, depending upon what you suspect. Just blindly sending all those investigation is not correct. So what you want, for suppose you want to rule out a urinary tract infection, you want a complete blood count, you want to see whether there is any neutrophilia, there you want to see whether there is any increase in complete blood count, CRP, all those elevation is there, you wanted to know, and maybe a urine routine, that will be sufficient enough. There is, when you are doing the examination, you find any organomegaly or any tenderness, significant tenderness, that is the time you can ask for an ultrasound abdomen. So that's the investigation that is necessary at that point of time. Just asking for all those investigation is not warranted. Suppose the child has got a right hypochondriac pain, right hypochondrium, there is a pain, so there is liver is there, so you can ask for an LFT. So like that, whatever is needed you need to ask in for. So just blindly asking a lot of investigation is not correct. So what is your focus, what is your diagnostic that you needed for the child, depending upon your primary assessment and your sample history and your focus evaluation, you ask for. That will be your priorities. Priority number 1, priority number 2, priority number 3. Suppose a child has come with a trauma, and what is the priority with the head injury? They have to do a CT brain. So like that, you have to have priorities. Rather than taking a fracture, there is a small injury onto the lower limb, you want to take an X-ray for that? No, that is not a priority right now. Our right now priority is to identify a life-threatening injury, life-threatening complication that a child has developed, and we need to treat that. So your investigation should be focused in a way that you wanted, whichever investigation you wanted as a priority should be done first. So that is, then only you will understand. You are asking for all investigation, you will not reach, because that you are just throwing a large net and you are getting a fish. That is not enough. You want to be very specific. This is what I wanted. This is what I suspect. I suspect a pneumonia in this type. So I wanted to know what is the inflammatory markers. Maybe CBC counts is increased or CRP is increased, and I want to get an X-ray. So that should be the initial investigation. So just asking for a child who have come with fever, cough and breathlessness, asking for a urinary routine is not needed at that point of time. So it all depends upon what you suspect. So those things only will come to know once you start seeing the children. Once you start seeing the patient, then you have to follow up this style. You have to follow up this report. Sending this report is not enough. So right now what we have just stabilized the airway breathing circulation. We have not done anything else. We have found some wheeze, we have treated that wheeze. That's it. So primarily what could be the reason for that wheeze? It could be a bacterial infection. So whether to start antibiotics, whether to give any other drugs, all those things depend upon your secondary assessment. So the next important thing, you have to have a diagnostics and you have to come for a provisional diagnosis. Suppose you are dealing with a patient with community acute pneumonia. So if it's a community acute pneumonia, the first thing that you are already A, B, C, you have stabilized. Next thing is you have to give some antibiotics to the child. So what antibiotics you need to say? Further management, whether the child needed to be admitted or discharged, that all decisions you need to make after you have done with your secondary assessment, diagnostic and with your provisional diagnosis. So the child is requiring oxygen and child is tachypnea. You can't send the child home. Definitely the child need to be admitted. Where to admit, whether to the ICU or whether to the ward. That again depends upon the oxygen requirement. Suppose the child is requiring 10 liters of oxygen. And what is the next step? If the 10 liters of oxygen fails, the child needed to be intubated. So there is no point of keeping the child in the ward. So that child needed to be in the ICU. Suppose the child is quite stable, playing around, and the child is absolutely fine taking oral feeds. No point required to admit the child. You can send them home with oral antibiotics. So these decision only comes, only you know when you start treating them and start following up this child. Majority of them can be discharged, but all depends upon the underlying comorbidities. The child is already having some cerebral palsy. There is a history of recurrent hospital admissions. So you cannot just send them home like that, because there is a high chance that this child will come back again to the ER with problems. So you have to be very, very clear which group of patient needed to be admitted, which group of patient need to be discharged. If admitted, where to admit, whether to the ICU, whether to the ward, all those decisions you have to get by only by experience. So your priority as an EMTs, your priorities will be to stabilize the airway breathing circulation, and you should be focusing your evaluation towards what is exactly required for the child. Your examination focus should be what is needed to the child. Maybe doing an abdominal examination for a patient with abdominal pain and asking investigations accordingly. Definitely a doctor will be there to help you out. But when you are alone, when you have a mass casualty, you have, suppose imagine that you have a large, you are going to a disaster area. Imagine that you are going to a disaster area. Maybe majority of them may not be affected by a direct disaster. Maybe they are coming to the camp because they have lost their home. So there is a lot of children there. So they have, parents are bringing them children, and doctor cannot see always. So you need to triage them accordingly, which needed to be, which child is sick that needs a definitive care. So which treatment is needed. Suppose that child is just coming with some, the common thing what can happen in this scenario is an acute diarrheal disease, because they are having common washrooms. They will be using common washroom. The hygiene will not be maintained in those areas. So maybe an acute diarrheal disease. So what you have to assess that dehydration status. The child is having dehydration, whether the child is able to tolerate oral feeds. Who needs IV? Who needs IV? Pretty simple. Who cannot tolerate IV fluids? So that dehydration part you can identify. And suppose the child is very much drowsy. So that child is very sick. So we need an IV access. So the child is able to take orally. Okay, well and good. You can start them on oral feeds, oral rehydration solution. So like that you will get an idea. So that is the basic idea why we are teaching you this. So whenever you see a child, you need to have a clear-cut idea what group of child is this, whether this child is sick or whether the child is stable enough, where can be managed by an oral medications or maybe without any medications at all, or which sick child we need to pick it up clearly, and that required treatment needed to be given on a timely manner. So that is all about your secondary assessment. Okay, thank you.